new face joining us up here, and that's Dr. Timothy Williamson, and he's a postdoctoral research fellow in the Department of Psychiatry and Behavioral Sciences at Memorial Sloan Kettering Cancer Center. And Dr. Williamson is also going to be moderating our survivor breakout session later this afternoon. So let's see, we're going to have Dr. Barrett, Dr. Schiller, and then Dr. Jennifer Garst, who many of you met last night, is going to be moderating our panel discussion today. So I think I'll let her kind of tell us how the flow is going to go, but we will have a microphone and have a chance for you all to ask questions of our panel.
Thank you, Paige. Thanks again, everybody, for coming out last night today. I hope everyone is excited as I am about the information that we've heard and brainstorming. Thank you very much to all of our participants. I think Timothy came from New York, Jim came from Virginia, Nadine sacrificed Janet Jackson. So we appreciate all of your efforts. And Timothy, since we didn't hear a lecture from you, will you please just tell us your background and a little bit about your work? Sure.
And thank you so much for having me. This has been an amazing day so far to meet so many people here, join in this advocacy. It's really great. Very happy to be here. I am a clinical psychologist by training that studies how different psychological and social factors can help or hinder adjustment to cancer. And most of my work has focused on lung cancer. And within that, most of my work is focused on stigma. So this is also an issue that I do care deeply about, like Dr. Schiller was saying. And about 5 years ago, I started a study that just as of yesterday finished its last piece of data. And so as I knew that I was coming here today, I quickly looked at some of the results to be able to share that with you as well. And this study was looking at lung cancer patients' experience of stigma over the course of time and what are the consequences of that stigma. And just to share some of the highlights from that research, we found that when patients experience higher levels of stigma, it has important consequences for health. And this was true for depression, for anxiety, quality of life, physical symptoms like shortness of breath and sleep problems as well. And this was true even when we adjusted and took into consideration patients' age and their gender, more so even than their medical treatment. And so we're taking this information from this research and really hoping to be able to share it both with the scientific community, the community at large, to show that lung cancer stigma is a public health issue and that this is a really important issue and that the next steps involve solutions and interventions to reduce stigma. And we believe that we can do that on many levels across interpersonal levels, structural levels, within our healthcare institutions and society and media. So there's a lot of work to be done, and I'm excited to hear what everybody has to share and collaboratively come up with ideas together that we can implement to reduce this stigma.
Thank you so much. Thanks for doing that very important work. Yeah, I mean, it's shocking that, how people perceive themselves or how others perceive them can actually impact the treatment that they get, their access to medical care, and the outcome, their longevity. It's really kind of shocking. So I think I have some prepared questions, but I think I want to give you a chance to ask your questions first. And we may actually cover some of these questions. So let's just jump right to it. Has anybody got anything they want to discuss or any burning ideas for our panel? Or non-burning ideas? Amy?
Well, I'd like to see Paige hustle anyway, so I had one that came up. We were, again, meeting with our focus group, small focus group of survivors, and I don't know, one of them brought it up or it just hit me like a hammer, but it was, when we talk about advocacy and stigma, it goes sort of both ways. And what I have seen, maybe anecdotally, but I think I've actually read this too, that a non-smoking lung cancer survivor or their family member is more likely to get involved with advocacy than a smoker or someone who has previously smoked. And you know, unfortunately, a large majority of people with lung cancer have smoked, either currently or formerly, and we do need to get them involved also, and we do need to hear their voices. So I guess my question is, why are they not involved with advocacy? I have some ideas. And how do we get them involved with advocacy in, for example, our organization?
Who wants to take that one on?
I can take the first part of it. And I think the reason that non-smokers are more likely to get involved is because they don't have that internalized stigma. They're not blaming themselves, they're not mad at themselves, whereas many smokers or former smokers unfortunately are. And so I think non-smokers are more likely to get mad and angry and reach out, whereas smokers are more likely to internalize it. I'm not sure how we get the smokers though to come out as well, and I think that's the big thing that we're struggling with is how to help them.
I would also, I agree with you. I think it is a challenge, and it's a great question. I think one of the things that would help, or that could help, is being able to create a space, a safe space for smokers to be able to feel like they belong in that conversation, in that dialogue, in that advocacy. And that's where I think part of what we were talking about earlier is how do we become, how do we create that platform? How do we create that space where that empathy, that sensitivity, that space where, no, this is our struggle, not just my struggle, yours is different because you're a smoker, but it's ours. And so it does take change in the language, change in the rhetoric, but also as teams that are involved in programs such as LCI and others, bringing people together to create that platform and then reaching out so people can actually hear that, oh wait, they're actually acknowledging me and respecting me as a person with lung cancer and not looking at me as I'm stigmatizing the whole group because I'm a smoker with lung cancer. So I think that it takes time. I don't think it's something that happens overnight, but I think changing our language, changing our focus, and being able to also become creating those advocacy spaces, it becomes that safe space for that person to feel, those groups to feel like they're a part of this program. And their strategies.
I think the other thing is that we have to, I don't know whether that means society or lung cancer patients or whom, but have to stop blaming the smoker and start more blaming the cigarette companies. Right? I mean, I think that's a big change that really needs to happen. You know, again, in the 60s, as I think somebody mentioned, it was all women in Virginia Slims and that type of thing. Earlier than that, the Army gave away cigarettes for free. And nowadays, it's teenagers, and teenagers they're vulnerable, and they can put whenever they want. They're often starting because of a lot of peer pressure and because of a lot of advertising. So I think you have to get away from blaming the smoker.
Overwhelmingly, over the last 4 years, they have come and risen to the occasion and supported me valiantly. So the smoker has to go out and to your peers and say, you know, I have lung cancer. We have to destigmatize ourselves. That would be my suggestion.
Yeah, thank you for sharing that. And I think too that in terms of that second part of the question of what can we do, and I think that question could be answered on many levels, and at least from the healthcare providers or from the healthcare institution level, one of the things if we look at stigma more broadly and specifically interventions that have been successful at reducing stigma, we can learn from them. And one of the first steps, if not the first step, is always acknowledgement and addressing the stigma, or in other words, naming the elephant in the room, right? That it's often in people's minds, but I think we need to make it explicit that this is something that advocacy groups are aware of and are fighting against and reducing. And specifically because I think for people with a history of smoking, some that I've spoken with maybe have been more reluctant to participate because they don't want to be lectured or face stigma from even an advocacy group, you know, and that should not be a concern. It should not be a barrier for someone to join an advocacy group. So I think that being able to call out the elephant in the room and to acknowledge it and address it and partner in the joint effort of reducing stigma may also be a way to help welcome people and build the survivorship group more broadly.
It's interesting, when we first started this whole lung cancer advocacy, one of the big discussions we had was, whether we would take on the whole smoking and, tobacco use issue, and we decided no, that was not our role. We wanted to help people with lung cancer, and we really didn't care, what the avenue that people developed lung cancer was. And so we actually excluded any kind of anti-smoking or whatever from our the points of things that we were going to take on. We were going to help people with lung cancer. We really didn't
I
care.
remember at some of our first meetings like this, when people talked and introduced themselves, we asked them not to mention
Yes.
whether they were a smoker or not.
Yes, yeah. But I think to Dr. Barrett's point, I think now maybe we should create some sort of healing the stigma forum and specifically invite non-smokers with lung cancer, smokers or ex-smokers with lung cancer specifically, so we can get those two groups to help heal the stigma. But I think that's something that we could definitely do. Yes.
The one that I have does not directly involve the VA. The partners that it involve are people who are vets as well, so they belong to the
So we
VA,
have vets,
but not actually in the health system. And we're actually having a listening session that's coming up, that's actually funded through the Lung Cancer Solution Fund, but that together. And we're excited about it because it's happening in October, and it's a group of the Men's Health Council that has, again, about half of them from the VA, and then the others are back then in the Greater Triangle area, and they're putting together a forum specifically around lung cancer and prevention and screening. And so I'm using that wheel that we were back then specifically to reduce smoking risks and understanding the impact of lung cancer. Some of them are men who are actual lung cancer patients, and some of them have relatives, their brother, for example, one who has lung cancer now. And so this is a big part of that work. So it's good when we have about 120 men that will be coming here and learn to the specific, and black men in particular will come to speak about lung cancer. So those are kinds of ways of advocating.
Yeah, definitely a high-risk population, and also a Duke, at least, our VA is literally right across the street, and our Duke faculty are basically the faculty members, the doctors at the VA. So there is an opportunity there.
Yeah, it's a wonderful question, and unfortunately there's no easy answer, of course, and everybody's different, and how these conversations unfold will vary based on several things. But one of the things that I think is important and that we're testing now at MSK is empathy, and thinking about joining with that person about shared goals or about shared feelings, whether it be for family or for health or whatever you can find that's shared with that goal. One of the things we're doing and we're testing right now at MSK is we've developed a communication skills training program for medical professionals, because there was this myth that empathy is innate, that you're either an empathic person or you don't have that bone or whatever it is. And we've shown through our research that is not true, that you can actually learn empathy and that it involves specific skills that are practiced. And so we're starting with the medical community, and specifically that clinical consultation that involves getting a history of tobacco use and asking questions about smoking, because those questions can be the most stigmatizing ones, even unintentionally. It may not be the purpose for somebody to cause a feeling of blame, but that's how somebody might feel when asked a question if it's phrased in a certain way. And so we've developed this communication skills training program, and we're testing to see specifically, can it reduce lung cancer patients' perception of stigma from their doctor or from their medical team in those clinical consultations. But I think that more broadly to your question, empathy is one of those ways that you can use as a gateway to start that conversation, talking about shared concern, talking about shared values, and shared goals. And you're exactly right in that. At the end of the day, people, we want that person's motivation and insight to be theirs and for them to own it. And at the same time, people are within a interconnected web of support with family and friends, and that is so important along that path. So anyways, I hope that helps.
Yeah, I mean, I can say for sure, you can absolutely teach empathy. And I would encourage every single one of you to start teaching your children, your grandchildren. You know, if you think of the old school, kind of like, well, you know, how would you feel if that happened to you? But, you know, but take that a step further and say, I want you to really sit down and let's think about what Johnny's going through. You know, his father's very ill, his mother is working 3 jobs. Maybe Johnny isn't getting enough to eat, maybe he's not getting enough sleep, he doesn't have the stability in our household that we have, and maybe that's why he's angry, and maybe he needs a friend, you know, and think about ways that you can reach out. I literally, empathy was one of the biggest things I wanted my children to have, both of them. And they have very different personalities, but I can tell you they are both extremely empathetic, and I'm very happy about that. To speak directly to your question, I think, you know, I would start that conversation by saying, Dad, do we have a little bit of time where we can just talk? Because I really, really want to talk to you about something that's been weighing heavily on me. And then you could say, you know, something like, there's more and more information about how harmful using tobacco is for your health. Joan just showed me a wonderful illustration the FDA just came out with, and it doesn't start with lung cancer for anti-smoking. It starts off with vascular disease and what it does to babies and what it does to children, and asthma and lung disease and heart disease and hypertension and skin. So you could start off maybe with this new FDA platform and say, you know, smoking is literally killing you. I mean, sometimes you don't need to hold back on words. And, you know, we love you very much, and I understand this is a strong addiction. I know you've tried many, many times to stop, but there are new methods to help you stop. And I think we should consider this and I'll go with you to your doctor, and we can talk about, you know, ways to stop. I'll support you. We can go to a smoking cessation class together. I mean, I think you have to give when you bring up something that you want to change, you have to offer an avenue for change, and you have to offer help in the same loving environment.
But Jennifer, don't you think they know that smoking's harmful?
Oh, I think they know it, and yeah, but I mean, I think they need to know that I think how much it's affecting their family and their health too. But you would take that out of the conversation?
No, it's just, I think, I would worry that if you start out by saying, you know, yeah, smoking's bad for you.
Well, I would never say that.
Well,
I wouldn't use those words. Again, I think your word choice is extremely important. I mean, I think it's important for people to know that there are new strategies to help people stop smoking, and that there are, you know, training programs, support groups. So there may be one way that we address that is, again, gently, and the time has to be right. I mean, it has to be right for, you know, addressing your eating addictions or your opioid addiction or, you know, whatever. We all have these addictions, or your alcohol, or whatever it is. The time has to be right, and the person has to be in a receptive place. So that's an excellent point. But I think letting people know that there are new ways, and asking people, well, you know, again, in the right environment, what have you tried, and what can we think about? Have you tried this? Have you tried that?
You usually try to get there eventually, but if you hit them with that up front, you've lost before you even started sometimes. Not always, but sometimes.
And just to go off of that point, those conversations you describe are, I too experienced them, and those exact conversations and those reactions are what prompted us to think about, okay, as providers and as a healthcare system, there must be a way that we can engage and communicate that does build trust and does build an alliance, so that people don't feel as defensive or anticipate that stigma from those conversations. And I think that it is, as you're saying, really important to sort of catch people at those times and to sort of change the conversation from what we've been having into one that's more empathic, more supportive, and more collaborative. Because in tobacco cessation, there are so many different levels that we can start with. And starting slow and starting gradual is sometimes very important. So I just want to say thank you for bringing it up, and exactly those are a lot of the encounters that I think that are important for us to be able to notice and change.
Dr. Barrett, do you have some insight?
I think when it comes down to having those conversations, I think everyone's kind of hit it that it's really about the timing, and I do love the language that you were just using around alliancing, creating that space where we're in this together. I also think that opening those types of conversations typically, or oftentimes, can be most helpful when maybe going into those conversations more from a space of curiosity versus from a space of, you need to, this is not, more saying, what do you think are like the challenges, or what are the things that we could probably do to make, and I'm still, even though I'm framing it, I still don't feel fully comfortable with that either, but I think the heart of it is to really think about coming to it from a space of curiosity and alliance versus coming at it from a space of, you have a problem that we need to fix, kind of a thing. And so, this is not my space, so I look to my colleagues for that, but I think from the spirit of it anyway, is really coming from a curiosity space of asking questions, and not questions that blame, or questions that lead to bridging, I think is the key piece.
Yeah, if you could avoid using words that create defensive behavior, I think that's a key. I was taught that if you quit smoking, your risk of developing lung cancer dropped back to that of a non-smoker over about 10 years. And that was wrong. I was taught incorrect information. And we now know that your risk does drop. Now your risk for stroke, hypertension, heart attack drops more significantly. But for lung cancer, the DNA damage, the field injury never goes away, and so it never gets back to that of a non-smoker. And that was, I was taught wrong information in medical school. Joan has a whole talk about this missing generation who quit when they were told to quit, like you, yet still, have these outcomes.
I think that's exactly right. There was a study done in Britain in the 1980s that followed physicians, translated male physicians, because they're smokers, and they showed very clearly that the farther away you get from quitting, your chances of lung cancer go down, but they never go down to zero.
That's so interesting. I'm almost kind of, I'm just saying this is a side note now, but like I said, sharing that Joanne and figure excellent question. I just came back from the Bodies exhibit in Boston a couple of weeks ago, 2 or 3 weeks ago. Has anyone seen that? Did you see the part on the lung cancer? It actually kind of reinforces the very issue you're highlighting, where they have the picture of the actual lung, the real lung of someone who had lung cancer, someone who didn't, and the stark difference between the two. And then in the report, it actually says something along the lines of what you said in medical school, when you read the, I was in Boston, so it's probably situated differently, but it actually reinforces the very issue that you're highlighting. And I even distinctly remember that there was a woman and her child that was looking, and the husband, the whole family was there, but they were looking at it, and it's like, look, honey, this is what happens when you have lung cancer. But if you don't smoke, or if you smoke, and I think the father must smoke or something, it can go just back to this. But the report, the document actually, from the museum, actually said the same thing. So even those kinds of stigmatizing spaces in a museum that thousands of people are going to, reinforces this thing that we're trying to kind of undo, right? But it was fascinating to see, without question.
So definitely accurate information, and education is key. People who have that similar experience frequently feel like they're undeserving of care, or they're undeserving of a cure, or they're undeserving of whatever it is. And sometimes physicians may even feel that way. Especially, I think Joan's work pointed that out as well. So that's something that we need to help with. Comments on that? Amy?
And we spend a lot of time with smoking, and I know that's a big part of the city.
what are the other reasons for stigma associated with lung cancer and lung cancer activity?
I can speak to that a little bit. Connected to this last question, that there's a Venn diagram where there is a stigma of smoking and a stigma of lung cancer, and a lot of that overlaps. That the smoking-related stigma sort of translates over into lung cancer-related stigma. There's also some stigma that comes from other sources or from other things as well. And some of what we see in our research is that there's a stigma more generally about disease, and particularly with diseases that are maybe more historically more severe or that are life-limiting more historically. And so that can be a part of this as well, or with limited treatment options that can be associated with, as Dr. Schiller was presenting, this even implicit idea of despair, which is, of course, informative when it comes to the stigma. I think it's also important that in our work that we show that there are different types of stigma. We talk about internalized stigma, but there's also perceiving stigma, just what you notice in your day-to-day life, and the idea of disclosure, that feeling uncomfortable or avoiding talking about the information, that's also a form of stigma, and that the perceived stigma and that constrained disclosure piece, that's actually, from what we're showing, is equivalent regardless of smoking history. So that there's a lot of, in lung cancer patients, so that there's a lot that is common in the experience of stigma in lung cancer patients coming from a lot of sources.
I mean, I have to agree. I have to believe that the smoking cessation efforts have somehow demonized smokers, because I'll tell you why. My kids, they start the anti-smoking stuff in elementary school. And I remember when my kids were young and they would see someone smoking, I remember my son going, "Oh my God, Mom, look at that man, he's smoking," like it was the most frightening thing he'd ever seen. And so, I'd like to know what's going into these anti-smoking efforts. Are they terrorizing children, and is that, how are they going about this?
On the other hand, my daughter smoked for about 6 months when she was in high school, and it was a rebellion thing, I'm
Yes.
sure.
Yes.
So teenagers are.
Yeah, well, he was a little boy. I mean, this happened, when he was like terrified, like hiding behind me because there was a man smoking, had learned personally, I mean, you can really manipulate your metabolism. And there is definitely a body of data, Thomas Siegfried, about ketosis and how ketosis impacts cancer metabolism. So I agree, in North America, we have poisoned our food supply, not just organic versus inorganic, but even processed foods that have literally been designed to be addictive and harmful. They change your metabolism so that you crave more of what you're eating. Europeans do not let their food be manipulated this way. So I'm coming to the place where I think big food is every bit as evil as the tobacco industry. I'm really getting there.
I was just going to say, so one of the things that I am often most amazed about is it's finally been documented that the incidence of lung cancer in never smokers is increasing. And why isn't there more of a hullabaloo about that? I personally think it is because it is particularly rising in women. Now, I'll bet if the incidence of fatal prostate cancers was going up,
Right.
there'd be bells and whistles and branches. Well, I mean, I just can't believe that there's not more epidemiological or looking into that. Personally, I guess I think it is because of the fact that the majority is in women, and we get back to the whole stigma regarding women, and women just haven't advocated well for themselves up to this point.
Why do you think that it's rising for women?
Well, it's rising, it is rising in both. It happens to be rising more in women, and I don't know the reason.
Well, I mean, type 2 diabetes is off the chart too.
Uh-huh.
And I mean, and Alzheimer's is off the chart and has now been renamed type 3. Alzheimer's has been renamed type 3 diabetes because it's thought that it has very much to do with insulin metabolism or glucose metabolism. So, I mean, there may be something in our environment that's leading to this.
One of the questions is it estrogen related? And there's a lot of data on either side of that.
There is a stigma among family practice internal medicine of many physicians that only smokers get lung cancer. And so we see a lot of non-smokers who have been misdiagnosed for months and months because it didn't pop into the head of their family doctor that this young person who hasn't smoked could get lung cancer. The signs and symptoms of lung cancer are extremely constitutional. And so they can be attributed to many things, you know, like bronchitis, like asthma, like, you know, being fatigued. So that's why lung screening is so important, but you would not have been picked up in lung screening. So the next thing that you need for people in your situation is an astute primary care physician who has lung cancer on their radar.
But is everybody like why they're not doing screening others? I mean, you have to have that set of criteria.
Yeah, so the only people that we're screening currently are people who are considered high risk, and that's age 55 to 80, have smoked, 30-pack years, and either still smoking or stopped smoking within 15 years. We talked a little bit about that last night.
And I also think that that's true with stigma. Thinking a lot about how we reduce stigma, of course, a lot of focus has been on the internalized stigma. But I worry that if we just focused on how to reduce internalized stigma, it communicates that it's the responsibility of the patient to undo all of the stigma. And we all, I think as society, as healthcare institutions, as providers, as friends and family, as in the media and messaging, there are so many levels that we can target this, and that it's that we don't want to inadvertently blame anybody, and that we can all share in risk reduction and also stigma reduction.
No, I totally agree both with what you have to say, Patty. I appreciate that. Always a patient advocate, and bringing us back to that point. And I think the point is totally valid in terms of it will take a multi-pronged approach to really address this. It's not, we typically tend to want to address these issues by focusing on one area or this particular area, bang, all day long. And while we're banging to get that down, this ugly other part is just rising up. And so I think that it does take us thinking, most certainly not blaming the patient, but also thinking about what are all the different multi-level institutions and individuals and groups that can play a part in different ways to address it. But without question, the take-home message has to be that we can't blame the patient for having lung cancer. We do have to think about ways to be quick to treat. And I think the other thing is that people who are lung cancer survivors, I'm going to just kind of throw this out there as a thought, but people who are lung cancer survivors who never smoke, sometimes you guys can probably be some of the biggest advocates of really advocating for those who are lung cancer survivors who did smoke. Because part of that message is sometimes that I'll hear it, and my mom has lung disease, she doesn't have lung cancer, she's on oxygen, etc. But she smoked for many years, my mom did. And so I think that one of the things that we can do as people who are lung cancer survivors to probably try to refrain from that space of saying, I'm a lung cancer survivor and I never smoked. Because just those two things alone kind of automatically shifts it into a blaming of the other. And say, I'm different from. And so even that, when I talk about our perceptions and what I did in that activity, I think we could probably start thinking about what are the things that I'm doing just in my own communication that I'm in fact endorsing the stigma without even realizing it, right? So even that in our language could be a big part of starting to shift that. And that's just my thought. So that's one way to kind of start thinking about it at an individual level maybe, of starting to shift that language and that rhetoric.
At one time, we had a "Why do you ask" campaign. Do you remember that? So that was because people kept coming up to us and asking, people, the first thing they asked me is, did I smoke? And so we came up with, what do I say to that? I mean, how obnoxious is that, I've got cancer, what difference does it make? And so we came up with this, well, why do you ask? And then we had an educational elevator spiel that you could give people. And you can give them a ribbon, and you can give them a, and say, this is a disease that encompasses all of us, So maybe we need to resurrect our "Why do you ask" campaign. If you have lungs, you can get lung cancer. And why do you ask? Or why do you ask? If you have lungs, you can get lung cancer.
It's that simple with breast cancer too, right?
Yeah,
You get breast cancer.
You're right. Is that exactly man or woman? All right, well, thank you very much. I think we're getting the hook here. And that was just an incredible, insightful discussion, and I thank all of you for contributing and giving us your thoughts.
Please join me in thanking our wonderful panelists.